Bismillahirrahmanirrahim. Our today's topic, we are going to start with the pleural lesions. And we know the pleura is a covering of the lung surface and the indigenous intimate inner surface of the thoracic cavity. So this important part will make us to understand the pleural pathology to be studied thoroughly, inshallah. So these pleural lesions, we make it to be headed in different topics like pleural effusion, pneumothorax, and pleural mass. And initially, what about the pleural effusion? We know by definition the abnormal accumulation of fluid in the pleural space is called pleural effusion. And pleural effusion, how does it look in the X-ray? In the total radiology presentation I did was basically based on X-ray findings because you juniors and students and the general practitioners have to meet and extrapolate before you enter into any part of other radiological modalities. So you need to be very much accustomed to explain an X-ray film and the commoner diseases encountered in everyday general practice. So I felt that from my corner, X-ray plate is such important that you must go through it meticulously and come to a decision without any confusion. So we are running with the X-ray films, and today again I am going to introduce you about the X-ray findings of different pleural lesions. Here you see how pleural effusion presents in X-ray. There is dense homogeneous opacity seen in the left, mid, and lower zones, obscuring the CP angle, ipsilateral hemidiaphragm outline, and also the left cardiac border. And this density has got no lung markings visible. This density has got a concave upper margin that is usually called the crescentic upper border. So this is the fluid space obscuring the detail here. You should ask me that why this is not a consolidation and why this is very sure that this is an effusion. Yes, this is the question I made so many times with me when I was a student like you or a learner initially. You see that wherever there is consolidation, basically it is mostly associated with some effusion. So consolidation and effusion is accompanying things together. Wherever you have some consolidation, you will get some effusion. Here, yes, consolidation is also present in this film. You see the denser part of the left lung is above this effusion. This is basically a collapsed and consolidated left lung. And even then, there is another opacity seen above the left hilum. What it would be that there is initially There's a consolidation was here in the left lung, producing effusion to be gravitated at the dependent part, and this may be a lymphatic mass over the left hilar and suprahilar region. And thus, this is consolidation. I decided on a way that yes, there is some lung markings or bronchosvascular markings. You used to talk about that. These are the bronchosvascular markings running through the whiter lung fields above this dense homogeneous opacity. Yes, there is another possibility. You cannot, and I cannot deny that there would be a consolidated, fully consolidated lung, and there would be no lung markings or bronchovascular markings producing a solid consolidated lung like this. Yes, whenever you get such a solid lung to be present, if you think of, but this is not going to give you a crescentic upper margin that gets to be finished at the lateral chest wall, and this concave upper margin and this homogeneous opacity. This goes in favor of consolidation not to be present. This is really an effusion. Thus, you try to go through the X-ray films and you come to understand that yes, there is association of effusion along with consolidation as a common scenario. Paired thing, really, I should say. This is a paired thing, but you should be very careful to declare consolidation and an effusion, especially when you are a beginner, when you are a junior. So this film has got consolidation. There is an effusion, and there is a perihilar and suprahilar adenopathy. What about the next? We were talking about pleural effusion. There is something you should know, that if you leave any effusion as anything with medication only, not any interventional drainage of the pleural effusion, it is losing its homogeneous and free characteristics. It gets separated. It is not staying just as anything. It is organizing, and subsequently there will be production of inflammation and abscess or fibrosis. So you must go to tap the fluid in the pleural space and let the re-expansion of the passively collapsed lung. Otherwise, what will happen? When there is a 72 hours accumulation of fluid in the lung, will eventually have some passive collapse to be permanent and will act as a leaders of recurrent pulmonary inflammation and infection for the rest of the life. So you need to tap, you need to make a paracentesis of the pleural fluid. And now we are talking about a free fluid in the pleural space. This is a dense, homogeneous opacity. There is no bronchovascular markings. There is obscured CP angles in relation. There is obscured hemidiaphragm in relation. Also, there is obscured cardiac borders in relation. It has got a concave upper margin reaching the lateral chest wall. Um, the upper limb of the concave margin reaches the lateral chest wall, and it has got no sharp margin, importantly, because the maximum motion activity in the body is really the arena, is the chest, because there is a continuously pumping heart and a continuously moving lungs together. It never produces a sharp margin for any time. So whenever the free fluid is present, it is also moving with the lungs and cardiac activities. So you are not going to have any sharp margin. Whenever you have got any sharp margin, that fluid is basically no longer a free fluid. It is an organizing fluid, organizing effusion or organizing fluid. And now we are going to talk about the loculated fluid in the pleural space. The loculated fluid, when there is organization of the pleural effusion present, it is a margin is seen. It is now a biconvex or lenticular shaped structure along the lateral chest wall. You see here, you have seen that the free fluid does not produce any margin. Now you can see that we have discussed something about the margin of an effusion. Whenever you have got a margin, this is a loculated pleural effusion. So what about the loculated fluid in the pleural space? It has got a sharp margin, and the medial margin is convex, producing a lenticular shape, and it may produce a persistent mass shadow along the fissural anatomy. Usually does not have any bony abnormality. Why the bony abnormality is here to be mentioned? Because whenever you have got loculated pleural effusion, it is lenticular shape, and whenever you will get a pleural mass, that is also going to produce a sharp marginated, convex marginated pleural lesion. The, and the mass now is to be differentiated from the loculated pleural effusion. So whenever there is no bony abnormality, we can think of that is an organizing effusion. And whenever there is bony abnormalities like erosion and destruction, we can think of an mass lesion. Uh, and these possibilities we used to talk about usually, but there is nothing no in the medical science that it would not be, this cannot be, this will never happen. We cannot say like this. So it is safer to say that usually we don't have any bony abnormality, but if there is any osteomyelitic lesion of an involved rib, and there will be lytic lesion in the rib and production of a convex abscess, that is also producing pleural fluid, but there is association of the bone erosion occurs. So usually no bone abnormality is seen with loculated pleural fluid. Now about the benign versus malignant effusion. In the initial classes, we talked about the benignity, and the malignancy can produce a big effusion and can be differentiated from the frontal chest X-ray. How I think I discussed earlier. Again, we just have a sweep over the benign and malignant effusion. Benign effusion and malignant effusion becomes a question when the effusion is very large and it obscures the pulmonary details. Then the question comes on whether this is a benign lesion or a malignant lesion. Thus, the large effusion usually obscures the igniting cause, the underlying cause, because there is large effusion. And the mediastinal shift will provide a clue to decide, because I have said that whenever there is a benign effusion, there is a large effusion will proportionately displace the mediastinum to the contralateral side. And this is the very logical and simple ethics of an abnormal accumulation in the pleural space producing positive pressure. And what about the malignant lesion? You see, this large effusion is displacing the cardiac right border up to the mid part of this chest cavity. And the other part, however, it is obscured, but the chest cavity on right side is showing the right heart border up to its middle part. So the displacement is definite. Also, the trachea is shifted towards the right side. And what about the malignant lesion? Here you see there is also a large effusion present, and there is no much tracheal shifting and no much mediastinal shifting in relation to this large effusion. So the summation is the positive pressure produced by a large effusion is really negated by the active collapse of the lung, affected lung, which has produced negative pressure due to atelectasis affecting the bronchus of the affected lung. So the positive pressure of the effusion and the negative uh, pressure produced by the active collapse and atelectasis at the hilum by a large mass really produces non-displaced mediastinum, referring you to a malignant effusion. That means a large effusion without mediastinal shifting must raise a suspicion of underlying malignant effusion. And we can see a large effusion simply. We can talk a lot about large effusion. And what about small effusion? All small and all large are really difficult always, but the average things are simple and known to everybody. Whenever you have a suspicion that this patient would have a small effusion, this is a critical space for a clinician that you need to deal that. You let the patient have a lateral decubitus view with the suspected part to be dependent. You can have a lateral view also because whenever you get a small effusion as a CP angle blunting, it is already having at least 100 ml effusion to be seen in a PA film chest, because the most dependent part of the thoracic cavity is lying with the posterior costophrenic angle that is to be filled by at least 100 ml effusion to be seen on the PA film as a small effusion. So whenever we say that this is a small effusion, this is not less than 100 ml effusion, you know. So you can have a lateral chest X-ray, a lateral decubitus view X-ray, the affected side on the dependent part, You can have a ultrasonography, sometimes fluoroscopy, and definitely CT scan can explain the presence of a small effusion. So the small effusion can raise a question, and the clinical suspicion will guide you to choose the modality of choice. Again, this is large effusion without mediastinal shifting. And this large effusion also has a convex upper margin so that there is organization. Maybe there is a hidden malignancy uh, that can also produce a convex margin and organization earlier. This is an example of malignant effusion also. Now we can switch to the pneumothorax. What is pneumothorax? Effusion, there is fluid accumulation in the pleural space, and similarly, pneumothorax is the accumulation of air in the pleural space. The definition is like that: the presence of air in the pleural space is pneumothorax, and how you like to describe it. Very interesting and very memorable, I think. And the X-ray of pneumothorax is very interesting, and I think whenever one can see it, cannot forget because of the tricky presentation of the X-ray film. I should say this is a tricky X-ray for the beginners, that apparently normal looking lung is having a pneumothorax unless you go it meticulously and very careful study you really need. You see, the pneumothorax is described as an X-ray having a hypertransradiant area without lung markings bounded medially by the collapsed lung margin. And what about small pneumothorax? Again, about small, like a small, small, like small effusion. We can also have very careful assessment of a um, small pneumothorax. You see, there's a very faint margin running here, over here, and here. You see that is a very subtle differentiation between lung field and pneumothorax. Just a margin, a faint margin, just um, making you just blunder that there is possibility of a pneumothorax. There is a very faint line here, medial to which there is a subtle increase in intensity, and outside there is the air here. So this is small pneumothorax. You must be very careful. And again, um, I have said that this is a tricky X-ray of the pneumothorax. You will be interested, and you will try to understand that how important it is. You see that there are the lung markings seen in in here, here, and here. How there are the vessels running in the lung fields. Mostly is not that difficult to understand. What about here? You see that these lung markings are really lost here, not seen outside. This is lost here, this is lost here, 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 and there is really no lung markings. Even then, these you can compare between the two X-ray here. You see that there is a very fine network of the vessel ends are seen over the ribs and through the lung fields. You see this, but here nothing is present. So there is a pneumothorax, and not that small. This is a sizable pneumothorax present here. So you have to be very crucial to understand to go through the um, pneumothorax and either present or not. Again, you see the way of reading an X-ray. You can see this film a bit detailed. I like to explain because maybe later on I may forget or I may not be able to be available with such film. You see the right lung is voluminous compared to the left one. Am I right? Because it is a large lung, right side, compared to the left one. The shape and the integrity of the lung markings is nice here, but the right lung has got a large volume, and there is, of course, at least the heart is really leaving the dorsal spine seen easily, and there is right cardiac border is left from the right side, and there is a small effusion here, and this is some pathology to be present here. You can gaze whenever you go to a chest X-ray. Initially, the total scenario will put you into confusion or in suspicion in that the lung volumes of the lung field. You see in a small field, a small scale that yes, there is a volume reduction or increase in the lung field. And the next is the mediastinal and of course the CP angles. This will be easier to you gradually, and gradually you try to practice yourself. So this is a voluminous lung here. There is small effusion here. The right hemidiaphragm is relatively flattened, and later on, whenever we see it closely, there were the black markings, the typical presence of pneumothorax, right? Again, this pneumothorax is not that difficult, I think. And the collapsed lung margin is well seen, and this is pneumothorax. And what about tension pneumothorax? We have to know very nice about tension pneumothorax because this is an emergency situation. Whenever you have got a pneumothorax, a breathless person with a large pneumothorax is a really acute emergency to be trained, and the tension pneumothorax produces a voluminous affected lung, the collapsed right lung along the high lung, and the mediastinal deviation to the left. And there is another term is large pneumothorax. There is also a very big pneumothorax in a chest X-ray, but there is not proportional effect on the mediastinal shifting or patient's clinical scenario. You see, there is a large pneumothorax. The whole lung is collapsed here. As a small mass it became. But you see, there is no mediastinal shifting. This is large pneumothorax. How you can declare it whether there is a tension pneumothorax or a a large pneumothorax. You see, this pneumothorax has produced, even there is the right pleural space, there is collapse of the right lung at the hilum, and there is the herniation of the right pleural cavity has crossed the midline, and there is mediastinal deviation to the opposite side, and so on. So this is a tension pneumothorax producing acute emergency. And in the chest X-ray, the important clue is the maximum mediastinal contralateral shifting is seen during inspiration. And what about large pneumothorax? There is maximum mediastinal displacement during expiration contralaterally. That means whenever you have got a medical emergency like tension pneumothorax, during inspiration, there is more compromise of the unaffected lung by the voluminous if tension tense pleural space that is causing emergency to be developed very seriously. And about large pneumothorax, there is no mediastinal, there is no positive pressure much, and there is no mediastinal shifting. Rather, when there is expiration, the mediastinum is displaced contralaterally. So the systemic effect is not that worse. That is an important differentiation between a pneumothorax, tension pneumothorax, and large pneumothorax. I think this is much enough you have gone through, and, the if there you have got any question, please you can ask me in the messenger. I'm here with you. Do you have any question? Viewers can ask me. If you don't have any question, or I have to wait or not. If you don't have any question, then I can leave the meeting. We'll meet you inshallah again. And